Let's talk about acute diabetic ketoacidosis. It's a very frequent question on the USMLE Step 2, and we're going to focus on some higher concepts. The first thing is with DKA, we need to understand the pathophysiology. Note that DKA usually presents in people who are insulin-dependent diabetes or type 1 diabetes. So these people, after they experience some infection or stressor or heavy alcohol intake, they may precipitate DKA. The pathophysiology of DKA, again, as we said, this is an insulin insufficiency pathology. So therefore, anything that leads to insulin insufficiency will mean that there's an elevated level of glucose. Why? Because the cell failed to uptake glucose. Glucose is high. So what happens? When glucose is high, the person has hyperglycemia, hence the pathology. And so what hyperglycemia does is causes osmotic diuresis, meaning that glucose serves as an agent that pulls water in. So if there's high glucose concentration in the blood, in the vasculature, it allows for water to be pulled in from the surroundings, the interstitium, which causes high blood pressure. So one of the things that we see in diabetic ketoacidosis is that the patient may have high blood pressure, but these are the main things that you want to watch out for here. So hypotonic losses, meaning that you have high osmolarity, and so you're pulling a lot of water from your environment. You may also have electrolyte depletion, meaning that you are excreting a lot of your sodium and your chloride and potassium through your urine. Okay, potassium can also be pulled into the cell, so you may have a hypokalemia. And the dehydration, again, you're getting rid of a lot of water, and then acidosis, of course, because you will build up a lot of ions. This part is very important. We're going to talk about the acidosis and how you correct DKA. So this is just an idea of the decrease in glucose uptake, what it leads to. The next thing is we need to talk about is proteolysis versus lipolysis. Lipolysis happens because your body thinks that it is in a starved stage for glucose. So it tries to find glucose from other sources. For example, the fatty acid. So fatty acid breakdown is called lipolysis. Your body also tries to find glucose from protein sources, and that's called proteinolysis. So in proteinolysis, essentially, you are increasing your nitrogen loss because you're breaking down the proteins, and you're increasing in your ammonium production. Recall that the reason why you're increasing your amino acid, sorry, I said ammonium, but I mean amino acid. The reason why you're increasing your amino acid is because amino acids can be salvaged to cause more glucose to increase. That process is called gluconeogenesis versus glycogenolysis. All right, so gluconeogenesis is the process of making new glucose from scratch, whereas glycogenolysis is the process of making glucose by breaking down the glucose storage, which is glycogen. Then you have lipolysis, which is important because lipolysis, you're breaking down free fatty acids to make precursors that are necessary to activate or improve gluconeogenesis. So glycerol 3-phosphate is what's actually produced here, and that goes into gluconeogenesis, and it helps with the whole hyperglycemia cycle. Free fatty acid can also be built up, and that can lead to ketogenesis. Recall that the ketone bodies are just essentially a form of transport of glucose that goes to different parts of the body so that they can be converted into glucose by undergoing the same process, so that you can get glucose storage. So the ketone bodies is important because ketone body can lead to acidosis. When ketone body build up, they themselves are an acid, or they have positive ion charges, so they lead to acidosis. That's why the pathology is called diabetic keto, because of the ketone bodies, acidosis. Now, ketone body is important because we need to understand the forms of ketone bodies and what they initially lead to. So ketone body increase in concentration will lead to ketonuria, meaning that there's a lot more ketone in your blood, but there's a lot more also in your kidneys that are being excreted through your urine. It may also cause Kussmaul's respiration. So now keep in mind, this here is a form of metabolic acidosis. Now in metabolic acidosis, what happens is that we try to compensate by activating our respiratory drive. So Kussmaul's respiration means that rapid breathing so that you can expel the acid. The acid form that you can expel of ketones are called the acetone. Now recall there are 3 forms of the ketones. There are acetone, acetoacetate, and hydroxybutyrate. You need to understand of these 3, where do they appear the most? Acetone appears in the breath. Patient may have a fruity breath, for example, whereas the higher concentration of the 2 are hydroxybutyrate, which essentially will be in the blood. So these are the pathophysiology you need to understand for diabetes. Now let's talk about the management of DKA. In DKA, the management involves you trending the anion gaps. it's important to know how to calculate the anion gap. Essentially, what you're doing is you're taking all the positive ions and you're taking all the negative ions and you're subtracting and trying to find the difference. Knowing that sodium accounts for the bulk of the positive ions and maybe a little bit of calcium and things like that, you literally want to have an anion gap between 8 and 12. Anything between 8 and 12, that's a normal anion gap. But in most people who come into the hospital with DKA, they tend to have high anion gap DKA. Okay, so the goal of treating DKA is to trend the anion gap to make sure that that is resolved. Once that is resolved, that gives you a benchmark as to how far the person is in terms of their DKA status. So the first thing they do, they come in, you give IV fluid, you give insulin, IV insulin, and you want to close the anion gap. Once the anion gap is closed, meaning that it's less than 12, you also want to measure the glucose. The glucose has to be less than 200, and the bicarbonate has to be above 15. And so if that's above 15, that's a closed anion gap, and you want to stop the insulin infusion. But recall that before you stop the insulin infusion, there's a 1 to 2 hour window where you have to give bolus, you have to get insulin injection sub-Q, which will cover the patient once you stop the insulin rejection to prevent reactivation of diabetic ketoacidosis. So this is what we're talking about here. You have a 1 to 2 hour overlap window where you have to give insulin sub-Q, and while the drip is continuing, the insulin drip, and then you stop the drip in that 1 to 2 hour window and just continue the person on sub-Q insulin. And of course, importantly, you want to replete the electrolytes. Let's talk about the electrolytes that are important to be repleted. Potassium, IV potassium is very important. Usually a potassium level less than 5.3. I'll say 5.2, you want to replete it. The pathophysiology is simple. Whenever there's an increase in insulin, insulin draws potassium into the cell. So if a person is DKA and they have high glucose and you're giving them insulin infusion, note that whatever potassium you see in the drawing is actually falsely elevated. They are actually pulling more potassium into the cell secondary to the high level of insulin infusion, right? When you also see that if the potassium drops between 3.3, that means it's actually a lot lower than this. So you want to stop any insulin infusion. You also want to replete bicarbonate, especially if the patient has a severe acidotic state less than 6.7. Phosphate should be given usually when it's less than 1. And then you also want to monitor the person's calcium. All right, so these are the things that you'll want to replete in the case of DKA. All right, so I hope this video makes sense. DKA, again, a quick recap. The pathophysiology involves insulin-dependent diabetes, which is type 1. It's due to decreasing glucose uptake. High level of glucose can cause osmotic diuresic pathology. Proteolysis and lipolysis will further exacerbate the hyperglycemia. The goal here is to trend the anion gap to see if they have high or low anion gap. And if it's high, you want to close it. And you also want to give insulin infusion with a sub-Q insulin injection to cover a 1 to 2 hour window where once you stop the insulin infusion, that they can be covered so that they don't have a relapse of the DKA. And then of course you want to replete all the electrolytes. Potassium, paying especial attention to potassium because of its strong connection to insulin. That's DKA.